Hello, friends. Welcome to my heart anatomy, blood flow, and EKG interpretation course. This is a PowerPoint that I created to use to study for an exam, and I'll be teaching it to you. This is going to go basically everything about how the heart works, how it pumps blood, the electrical activity of the heart, and basic EKG rhythms. So I'm sure you're familiar with watching a TV show and you see the monitor. Like, for example, I'm sure you've seen a movie and you'll see the little lines that go up and down in like a hospital. And I'm also going to be actually explaining to you what those EKG rhythms are and how to interpret them and how you can understand how that relates to what is actually going on inside of the heart. So this is something that was required of me for my paramedic course, obviously, because anyone that's having chest pain or a respiratory complaint, you're going to want to do a 12 lead EKG on because uh, cardiac maybe arrhythmias could cause respiratory issues or many things could cause cardiac abnormalities. So it's good to understand these rhythms, right? All right, so this is your heart, right? So, general rule of thumb, A is away. So, an artery goes away from the heart, and a vein goes towards the heart in relation to blood, right? So, blue represents deoxygenated blood, red represents oxygenated. So, deoxygenated blood comes from the rest of the body, and it originally comes into the superior vena cava on the right side, into the right atrium, through the tricuspid valve into the right ventricle, and then it goes through here to goes to the pulmonary artery, and then from the pulmonary artery it goes to the lungs, and then it returns from the lungs into the pulmonary veins. And then as you can see, when it goes from the pulmonary artery to the pulmonary vein, it becomes oxygenated in the lungs, and then it returns through the pulmonary vein into the left atrium, and then through the aortic valve to the left ventricle. Wait, no, not the aortic valve, the mitral valve to the left ventricle. And then from the left ventricle, it goes to the aorta and goes out to the rest of the body. So the heart is a four-chamber system. So you have your two atriums at the top and your two ventricles at the bottom, right? So it is a four-chamber system. It comes in on the right side of the heart, goes to the lungs to get oxygenated, right? And then comes back through the left side of the heart to go out to the aorta to the rest of the body. That's why it's called a cardiopulmonary system, because your cardio is your heart, your pulmonary is your lungs. It's very important that both your lungs and your heart are working properly because the entire system runs together, right? So this diagram basically just shows everything exactly what I just explained to you. So blood flow through the heart comes in from the body through the superior vena cava, right atrium, tricuspid valve, right ventricle, pulmonary artery to the lungs, pulmonary vein, mitral valve, left ventricle, aortic valve, aorta, right? And this is a screenshot from ChatGPT, basically just explaining the function of the organs. So superior and inferior vena cava bring deoxygenated blood from the body into the heart. Right atrium, blood fills this upper right chamber. Tricuspid valve opens to let blood flow downward. And you get the gist of it, right? Right? Makes sense? It is the exact same thing, just kind of just like my notes explaining blood flow in the heart, right? So as you can see, it's kind of Step-by-step process: superior vena cava, right atrium, tricuspid valve, right ventricle, pulmonary valve slash arteries, goes to the lungs to get oxygenated. Lungs, pulmonary vein, left atrium, mitral valve, left ventricle, aortic valve, aorta goes to the rest of the body. So, what is an EKG? Right. So, EKG means electrocardiogram, or also known as ECG. They're kind of used interchangeably. And EKG basically measures the electrical activity of the heart. Right. So, for an EMS or in a hospital, if a patient is complaining of chest pain, you're going to do an EKG on them. So you're going to put the stickers on them, and there's specific ways that you place them. And that EKG is going to take a picture of the heart, and that picture is going to give you a rhythm. And there's also a 12 lead EKG as well, where you take 12 views of the heart. But basically, that EKG is measuring the electrical activity of the heart and what is happening inside of the heart. So, with what I was saying um, earlier, right? Like, there's an EKG, right? So I'm sure you've all seen like a classic hospital movie where you see like the lines and whatnot. That's what an EKG is, and it can tell you what's happening in the heart. So arrhythmia and dysrhythmia. Arrhythmia and dysrhythmia, those two words are kind of used interchangeably. They mean the same thing. It just means an abnormal heart rhythm. That was one thing that I was curious about when I started. I was like, what is an arrhythmia or a dysrhythmia? It just means abnormal heart rhythm. Anything that's abnormal. So, for example, potassium, sodium, and calcium are three electrolytes or three elements on the periodic table for any of you that have done a chemistry course that affect cardiac muscle, right? So, potassium, sodium, and calcium affect your cardiac muscle. So, if any of these electrolytes are out of whack or not normal, that can cause EKG disturbances. So, once you study this for a while, you can actually look at a rhythm and you can read it and you can say, oh, yeah, this person has high potassium, or this person has low potassium, or this person has high calcium, or this person has low calcium. So, any abnormalities in any of these electrolytes can cause EKG disturbances and maybe make your EKG look abnormal. So, it could cause what? Abnormal, an arrhythmia, or a dysrhythmia, right? So we went over the mechanical blood flow of the heart, right? But this is the electrical aspect of the heart. So your heart here is basically its own pacemaker, right? There's electrical activity in the heart that causes the heart to beat, right? So this at the top of the heart is called the SA node, right? This is the AV node, and this is the ventricles down here, right? So for most people, they're going to get an electrical impulse at the SA node, then go to the AV node, and then go down to the ventricles, right? So it goes one, two, goes down the rest of the heart, and that flow causes the contraction of the heart, right? So there are also things known as bundle branch blocks. So say if there's like a block on maybe the right side of the heart and there's a right bundle branch block, or there's a left bundle branch block, or they might both be blocked. You can also read that in the EKG as well. And it might be important to note because, like, hey, like if an electrical impulse isn't going to the heart the way it's supposed to, that could cause arrhythmias, that could cause abnormal heart rhythms, right? Which may not be good. But just keep this in mind: SA node, AV node, because depending upon which node a heartbeat originates from, can change what your EKG will look like. And you'll learn that in just a second. All right, so this is going back to the sodium potassium pump. Sodium is outside of the cell, potassium is inside of the cell. Sodium enters the cell via the sodium potassium pump. So if you look over here on this right side, This right here is a normal sinus rhythm. So if I were to do an EKG on you or the majority of people, I would probably get a normal sinus rhythm, and this is what it would look like. So that EKG that you see in the hospital, this is basically what it means. You have this first wave right here, which is called your P wave, and then you have a QRS complex, and then you have a kind of like a resting phase here, and then you have your T wave. This is what each of those little that's what one cardiac cycle or one heartbeat means. So this is one cardiac cycle right here. You have a P wave, a QRS, and a T wave, right? And the P wave is the depolarization of the atrium, so atrial depolarization. Your QRS complex is the depolarization of the ventricles, and your T wave is the repolarization of the ventricles, right? So as you can see, ventricles are a lot bigger than the atrium. So you can see right here, the ventricles are bigger, they're thicker. That's why it has a bigger depolarization. There's more voltage, right? And you don't really see the repolarization of the atrium because it kind of gets lost in the QRS, right? So this is the depolarization of the atrium, depolarization of the ventricles, and then the repolarization of the ventricles. And this is one heartbeat. This is what a normal sinus rhythm looks like. And you'll understand more on that in just a minute. So, polarization, resting phase, depolarization, sodium and calcium enter the cell, potassium leaves, flow of electricity causes heart contraction. So, during one heartbeat, right, you have these electrolytes that are obviously causing this to occur, right? And this is what causes um, the heart to contract because you have an electrical impulse, right? That's causing this, and that impulse causes the heart to contract. So, as I just discussed earlier, if there's abnormalities in an electrical impulse, that can cause your heart to beat differently, right? And these are just some medical terms here. So, just in general, hypo is the root word for low, and hyper means high. So, anything you hear hypo means low, hyper is high. So, hypertension is high blood pressure, hypotension is low blood pressure, hypovolemia would be like low fluid volume, hypervolemia would be excessive fluid volume, right? So for sodium, hypernatremia means too much sodium or excess sodium. Hyponatremia means a low sodium. And then for potassium and calcium, hyperkalemia for high potassium, hypokalemia for low potassium, hypercalcemia for high calcium, hypocalcemia for low calcium, right? So as I mentioned earlier, there are three pacemakers in the heart: the SA node, the AV node, and the ventricles, right? So, majority of people, your primary pacemaker is the SA node. In most normal, healthy people, the primary pacemaker is the SA node. SA node, an electrical impulse goes from the SA node to the AV node to the ventricles, right? But say people that are older or the SA node stops working, then the AV node will become the primary pacemaker, right? So most people, their primary pacemaker is the SA node, right? But let's say the SA node stops working for whatever reason, right? The AV node will take over as the primary pacemaker. And then for the same thing, if the AV node stops working, then the ventricles will take over as the primary pacemaker. And then if the ventricles stop working, then that's it, right? So when one pacemaker fails, the other one takes over to basically compensate for it, right? And your ventricle is your last one, right? So just get back to that in a second. So a normal heartbeat in a normal healthy person is 60 to 100 beats per minute. So when the SA node is the primary pacemaker, normal heartbeat 60 to 100 beats per minute. For an AV node, which is also known as a junctional rhythm, which you'll see in the EKG in a second, a normal heartbeat is 40 to 60 beats per minute. So it's slower. And then for the ventricles, it's even slower. It's 2 to 40 beats per minute, right? If the SA node fails, the AV node will take over. If all three fails, cardiac arrest, eventually death, right? And that could also be another problem because let's say for example, your heart is going to beat to obviously pump blood around your body as we just discussed to perfuse your organs, to perfuse your brain, to perfuse your kidneys, to perfuse your skin, right? To get oxygen, get blood to everywhere that needs to be. So if your heart beat is too slow, so say if you normally beat at 60 beats per minute, but then you're only beating 20 beats per minute, you're not getting the same cardiac output as you're used to. Your heart isn't pumping as much blood that your body needs to perfuse your organs. So that's another thing to just put a pin in to think about, right? Of why having a too low heartbeat can be dangerous. Well, also having a very high heartbeat can be dangerous as well. And we'll get into that in a second. So when someone says the word lead, it just means view of the heart. So when someone says we look at a 12 lead EKG, we're looking at 12 pictures of the heart, right? Because when you put an EKG on a person, you put what's called on stickers. So in an ambulance, you would put EKG stickers. So you have um, it's like V1, V2, V3, V4, V5, V6, right? And each one of those stickers is called a lead, and it takes a different picture of the heart, right? So when someone says lead, it just means view of the heart or a certain view of the heart. And if you have a upright deflection, that's just showing that electricity is flowing in the positive direction, and downward flow means it's flowing in the negative direction, right? So in a normal heartbeat, in a normal healthy person, and what we would call a normal sinus rhythm, it would look like this. You have a P wave, you have an upright QRS complex, and an upright T wave, right? But you might have, say, inverted P waves or inverted T waves, right? So you know that electricity is flowing in a different direction, right? So a normal QRS, which is, we just go back right here, is 0.08 to 0.12 seconds, right? A normal QRS. If you have a wider QRS, meaning it's longer than 0.12 seconds, there could be a bundle branch block or it could be supraventricular. Why no? If it's if you have a wider QRS complex, meaning it's slower, there could be a bundle branch block or it could be ventricular in origin. So that's why it could be slower. It could be the ventricles are taking over as the pacemaker, or there could be a bundle branch block. An ectopic beat are basically extra heartbeats that originate somewhere in the heart other than the SA node. So an ectopic beat is just an extra beat, basically, right? So if someone says they have a sinus arrhythmia, that means the R to R is not constant, right? So, for example, this is a normal rhythm, right? So you have your P wave, your QRS, and then your T wave. So think of the R here as this top point here, right? So one thing when you're looking at an EKG to know if it's normal or abnormal is look at the distance between each R to R, right? So as you can see here, the R to R is equal, meaning that it's normal. But if someone has a sinus arrhythmia, the R to R interval will not be constant. So let's say, for example, it could be constant for a couple seconds, and then I could take a breath, and then the R to R will just be more spread apart. That would be known as a sinus arrhythmia, which isn't necessarily dangerous, right? But that's what it means. It's very common in young and healthy people. So, say if you take a deep breath, maybe your R to R will be longer, and then if you breathe really fast or breathe out, it will be more closer together, right? That would be known as a sinus arrhythmia. So bradycardia means slow heart rate, right? And tachycardia means high heart rate. So normal heart rate is 60 to 100 beats per minute. Bradycardia is slow heartbeat, so below 60 beats per minute. And tachycardia is high heartbeat, so above 100 beats per minute. So this is a normal sinus rhythm. It's normal. You have your P waves, you have your QRS, you have your T wave. Your QRS is between 0.08 to 0.12. The R to R is normal. So you know it's a normal sinus rhythm. It's between 60 to 100 beats per minute. And the way you can actually look at the EKG and count the pulse is because what's the best way? It's very hard to see the very tiny boxes here, but each very small box is 0.04 seconds, right? So what you want to do is, for example, if you want to calculate the heart rate, count the number of big boxes between each R to R. So as you can see from about here, it looks like there's one, two, three, four. It looks like there's four big boxes between this one. And as you can see, if you want to count from this one, it looks like there's about one, two, three, about four boxes. To get the heart rate, take 300, right? Just take the number 300 and divide by the number of big boxes between um, each one, right? That's how they taught me to do it in school. Because looking at it more closely, right, that will give you the heart rate. So, for example, as you can see, there's four boxes between each R to R. Take 300, divide it by the number of boxes, which would be four, and that will give you 75 beats per minute, right? So, as you can see, 75 beats per minute, that's between 60 to 100. So, that will be a normal rate. So, with this, you look at it, you can say, okay, P waves upright, QRS upright, followed by T wave, R to R is equal 75 beats per minute. Okay, it's normal sinus rhythm. But you see here, like look right here. All right, you have your P wave, you have your QRS, you have your T wave, P wave, QRS, T wave, R to R is equal. But look here, there's one, two, three, four, five, six boxes separating these. 300 divided by 6 is 50. So this is 50 beats per minute. So everything is normal. It's a normal sinus rhythm, but it just has a slower heartbeat. So this will be known as sinus bradycardia, slow heartbeat. And for right here, you can see, all right, P wave, QRS, T wave, P wave, QRS, T wave, R to R is equal. You looks like you have two boxes, maybe two and a half boxes separating each one. So 300 divided by two and a half is about maybe, what's that? It's between 100 and 150. So 300 divided by 2.5 is 120. So this is 120 beats per minute. So it'll be known as sinus tachycardia because P wave, QRS, T wave all look normal. R to R is normal, but it's 120 beats per minute. So it's still a sinus rhythm because it's coming from the SA node, but it's tachycardia. So it's sinus tachycardia. And this is, as you can see, is an example of an arrhythmia or a dysrhythmia because you have your normal sinus rhythm right here, and then right here, the R to R gets longer. So, for example, this could be like me just being normal, and then say I take a deep breath, and then all of a sudden my R to R is abnormal and it's different. That's known as a sinus arrhythmia. Wolff Parkinson's White is a condition where your QRS complex is a bit spiked. So you kind of have this delta wave here. So instead of having a straight line up, there's this delta wave. It's called Wolff Parkinson's White syndrome. And it's a condition that can make your heart rate get really, really fast, really sudden, and it makes it easier for you to go into cardiac arrest. So that's a syndrome that is good to know, right? All right, so atrial rates. So I'm sure you've probably heard of AFib or A flutter, which are two more cardiac rates. So what's the best way I could explain this? I'll come back to that in a second. But this is A flutter, right? So A flutter, you have a QRS complex, but in between the QRS complex, you have these little flutters here, right? So this is the atria just going crazy and acting abnormal, right? So it has a QRS complex, but the waves in between the atria are acting up, right? So that's known as A flutter. And with atrial fibrillation, it's kind of the same thing. It has a QRS, but instead of it being like a flutter, it's kind of just like more like little. It's not as organized, right? If that makes sense. It's kind of like little squiggles, right? So that's a picture of what atrial fibrillation would look like on a monitor, and this would be A flutter. So as you can see, A flutter, it's a bit prettier, right? So A flutter, your R to R is equal. You kind of have these little flutters here. But with A fib, your R to R is unequal. So it's not regular. And it kind of has these little, not as pretty little spikes here, you know? So A fib is called regularly irregular or regularly regular. That's, yeah. So going back to this, atrial rates. Atrial rate becomes faster than the SA node. Atria will take over as pacemaker. Already talked about ectopic beats. That's talking about a PAC and atrial flutter. So with atrial flutter, as I was just talking about, so the atria becomes very irritable and it fires faster than 250 beats per minute. Ventricles do not have enough time to fill between beats and cannot eject enough blood to meet the needs of the body, can cause hypotension, which is low blood pressure. Although atrial rate is high, ventricular rate is slower than that and is the actual heartbeat. So if atria fires 250 beats per minute, the actual heart rate may be 150. So say, for example, if someone's atria isn't acting normal, you can get these abnormal rhythms, right? So if the atria isn't, you know, filling, if the atrial chamber isn't filling with blood like it's supposed to, you can get these rhythms. So the atria might be firing at 250 beats per minute, but that's not going to be the actual heart rhythm. So the atria could be firing really fast, but the ventricle, could be acting normal. So the heartbeat won't actually be 250 beats per minute. It'll just be out 150. And AFib and A flutter are actually not fatal rhythms. Like obviously there are some rhythms that we'll get into later that are fatal rhythms, but there are some people that have AFib and A flutter and they just live with it and they take medications and that might just be their normal for them, right? So AFib is generally not considered a lethal rhythm, right? Some people just live with it, but this is what it looks like. If you see it on a monitor, it has a normal QRS. Flutter kind of has little flutters in between. R to R is equal for A flutter. A fib, R to R is unequal. It has a QRS and it has these little these little spikes in here. And that is basically the atria not doing what it's supposed to, right? And some people live with this. Okay. So premature atrial complex, if I'm going back here, it's an irritable beat in the atria, right? So it's an irritable beat in the atria. So as you can see here, you have your normal heartbeat. Oh, and then you have a right there. There it is. Goes back to being normal, and then there it is, right there. So this is a P wave is present, but it may look odd. This is known as a PAC, a premature atrial complex, which is an irregular beat in the atrium, right? Multifocal atrial tachycardia, on that. So junctional rhythms. So as I mentioned earlier, most people have a sinus rhythm, which is where their heartbeat originates from their SA node, which is normal for most people. But say if the SA node stops working, the AV node will take over as the primary pacemaker, and then that is known as a junctional rhythm. So we go from sinus rhythm to junctional rhythm, right? So as I mentioned earlier, the AV node, the pacemaker, is 40 to 60 beats per minute as opposed to 60 to 100, right? So with junctional rhythms, one thing that is noticeable on an EKG is that a P wave will not always precede the QRS complex and may be absent or inverted. Really just depends on whether the atria or the ventricles depolarize first. The PRI interval, which is the PR interval, which is this, for a junctional rhythm, may be less than 0.12 because it takes less time to reach the ventricles from the AV node as opposed to the SA node because it's lower, right? So there are different types of junctional rhythms that originate from the AV junction. There's a premature junctional complex, a junctional escape rhythm, junctional tachycardia, accelerated junctional rhythm, and SVT, which is another rhythm that is a bit different that I'll talk about later. So a premature junctional complex is a single irritable beat in the AV junction. PJC interrupts regularity of actional rhythm. P wave may be inverted, absent, and can be before, during, or after a QRS complex. So as you can see here, here's a premature junctional. So as you can see right here, looks like it's right here. So it's an irritable focus in the AV junction. So it looks here there was an early beat. And as you can see right here, you have your P wave, your QRS, your T wave, and then you have this QRS right here, but there's no P wave, right? That's a PJC. It's absent or inverted. So this is a junctional escape rhythm, or also known as a kind of like a normal junctional rhythm. It's called the junctional escape rhythm. It's this. It's like this. It has a QRS and it has inverted T waves, but no P waves. And as you can see, the heartbeat is a bit slower. So we can count the pulse by counting the boxes. So 1, 2, 3, 4, 5, 6, 7. 300 divided by 7 is 300 divided by 7. It's about 43. So 43 beats per minute here, which is low. This is a junctional escape rhythm. So no upright P waves, it's junctional. So if you don't see a P wave, and especially if you see inverted T waves, and you know the heart rate is slower, think junctional rhythm coming from the SA node. And this is an accelerated junctional rhythm. So an accelerated junctional rhythm is a junctional rhythm, but just between 60 to 100 beats per minute. So accelerated junctional rhythm is a junctional rhythm, but just at the same heartbeat as a normal sinus rhythm, right? That's why it's really important that you look at an EKG and understand how to read your rhythms so you can understand what's actually going on with your patient as opposed to just looking at the pulse. Because let's say you're in the back of the ambulance and you put a pulse ox on someone and you say, okay, this person has a pulse of 100. That's a normal heartbeat, right? But you could have missed that it was a junctional rhythm. You could have just said, "Oh, it's 100 beats per minute. That's a normal heartbeat." But you could have missed that it was a junctional rhythm, which might be something to important. You never know. So this is accelerated junctional rhythm, and this is junctional tachycardia. So junctional tachycardia is a junctional rhythm, but above 100 beats per minute, right? Yeah, junctional tachycardia, 100 beats per minute. So you can see here, you have a QRS and you have upright T waves but no P waves, right? Junctional tachycardia. So heart blocks, right? So as I mentioned earlier, I showed you the electrical activity of the heart. So let's say there could be a block. There could be a block in, say, the right bundle branch. That could make it harder for an electrical impulse to go down to the right side of the heart, right? But there are different types of heart blocks, right? And this is referring to electrical blocks. Obviously, this is completely different from a myocardial infarction, which would refer to like an actual like blood flow blockage, but this is referring to like an electrical block, right? So there's a first degree block, which is least serious, and I'll show you what that is. And there's a second degree block type 1, also known as a Winky block, which I'll show you. And there's a second degree heart block type 2, also known as a Mobitz, which is not good. Well, really, no heart blocks are good. So if you do it EKG on a patient, it might be important that you catch it, right? Because say if someone has especially if they have a third degree heart block, which I'll talk to you about in a second, that's something you might want to notify to the doctor, right? And there's a third degree heart block as well, which there's a complete heart block at the AV node. SA node cannot get to the AV node. So they're basically, the atria and the ventricles are not communicating at all, and this patient will need pacing or they'll probably go into cardiac arrest. The atria and the ventricles fire and function independently, right? And then getting back into some ventricular rhythms, these are the most dangerous rhythms. Impulse originates in the ventricles, heart efficiency is reduced, no backup system after the ventricles. QRS will be wide and greater than 0.12. And these are types of ventricular rhythms that I'll go over in a second. And as I mentioned earlier, the reason why ventricular rhythms are so dangerous, because as I mentioned earlier, you have your SA node, your AV node, and then your ventricles, right? So after your ventricles, there's no more pacemakers, right? So if the ventricles fail, your heart isn't pumping blood, and then you will die, right? So this is a first degree heart block. So a first degree heart block, you can tell it's a first degree heart block because you have your P wave, your QRS, your P wave, your QRS. But you notice, like right here, your P wave is getting progressively farther and farther away from your QRS. So as you can see here, P wave is getting farther apart from QRS, as opposed to, you see this, right? That's known as a first degree heart block, which is really not serious at all, but that's what it means. Is the P wave is getting farther away from the QRS with each progressive beat. Because this one thing right here is a B, right? And this is second degree heart block type 1 is it's kind of like the first degree heart block where you see, all right, you have your P wave, your QRS, your T wave, everything looks normal. The P wave is progressively getting farther away from the QRS until eventually it skips a beat, right? So as you can see here, normal, P wave gets farther away from QRS, P wave gets farther away from QRS, and then right here it skips a beat. It skips a beat right here, right? And then it goes back to being normal. That's a type 1, where it gets progressively farther away and then it skips a beat, right? And this is type 2, also known as a Mobitz, right? So this is kind of like a type 1, except it's skipping beats more often or skipping beats frequently. So as you can see here, normal, 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 skips a beat. So there's a P wave, no QRS. Second degree, normal, 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 P wave, no QRS, normal, normal, no QRS. So second degree heart block type 2, it's frequently skipping beats, right? And that's not good because I mentioned earlier, if your heart is skipping beats that it should normally be having, that's not going to help you perfuse. It's not going to give you more cardiac output that you need, especially if your heart is skipping beats frequently. And this is a third degree heart block, which is not good at all. This is where there's a complete heart block. There's basically no electrical impulse going through. The atria and the ventricles are not communicating at all. And like you can see this, there's a P wave, there's a P wave here, no QRS, there's a P wave here, no QRS. Basically everything's out of sync, and this patient is going to need pacing. Because at this rate here, this person's heartbeat is around 30 beats per minute, just in this rhythm right here. And 30 beats per minute is not good. It's not going to help you perfuse, right? So this person would need to be paced to help increase the heartbeat, right? And they might need a pacemaker as well. Ventricular rhythms, a PVC is a premature ventricular contraction. So it's a single ectopic beat from the irritable ventricle, earlier than expected, interrupting an underlying rhythm. And I'll show you what that looks like on an EKG in a second. So a couplet is known as two PVCs in a row. A run of PVCs equals three PVCs. Three PVCs in a row. A run of VTAC, which we'll hear about in a second, is more than three PVCs in a row. Signs of significant heart irritability is having a lot of PVCs. That means that the heart is irritable. And bigeminy is a PVC every other beat. Trigeminy is PVC every third beat. And then quadgeminy is a PVC every fourth beat. So you can see here, this is a PVC. This is a normal sinus rhythm right here. You have your P, your QRS, your T wave, R to R is equal, and then you have this big kind of thing right here. That's a PVC. So usually on a PVC, you'll see the beat, like you see the beat right here in the monitor, but there might not have been an actual heartbeat. So when I was doing a clinical one time, and I had a patient that was having bigeminy, so they were having frequent PVCs, right? You want to feel their radial pulse because the monitor might say that their heartbeat is 60 beats per minute, right? But if they're in bigeminy and every other beat is a PVC, the monitor will say they have a heartbeat of 60 beats per minute because it's counting that PVC as a beat. But in reality, they're only actually beating about 30 times per minute because you can feel their radial pulses and you can feel, okay, when there's a PVC, I don't feel the pulse because you can feel your radial pulse right here. You can feel your carotid and you can feel the patient's pulse. You can say, okay, when they have a PVC, I don't feel a pulse, right? So that's another thing you always want to keep hold of, especially when you do pacing, which I haven't really talked about at all. It's very important that you want to actually make sure that you feel a pulse, you feel a beat. That's actually, that if it's showing up on the monitor, you want to ensure that it's actually showing up in the patient. It's actually helping the patient beat. Because the monitor can lie to you. The monitor can tell you there's a beat, but if you feel a pulse and there ain't no pulse, then they're not perfusing, right? So that's a PVC, right? This kind of weird lumpy mountain thing that just comes out of nowhere, right? And this is SVT, supraventricular tachycardia. So if someone has a really high heartbeat, say 200 beats per minute, you'll see this. And right here, it's just QRS, 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 QRS. And you can't really see the underlying rhythm here. So you don't know. This could be any rhythm. This could be don't really know this could be. This could be AFib. This could also be sinus tachycardia. You really have to slow this down. But if you see a very, very fast rhythm where the rhythm is so fast you don't even see P waves, you just see QRSs because it's so fast, think SVT, supraventricular tachycardia. So this, for example, is SVT. Just a really, really fast heartbeat, right? So you can see here the heart is beating so fast. Well, you can kind of see a P wave here, but you don't have a T wave. So you got to slow this down, right? Because this heartbeat right now is about 200 beats per minute, 220. It's a very fast heart rate. Not good. Maybe an RT. All right, so dangerous rhythms. Now getting into our lethal rhythms is ventricular tachycardia. Extremely irritable heart. The ventricles override. Sustained run of PVCs. Ventricular rate is 100 250 beats per minute. So when someone is in VTAC, right, ventricular tachycardia, the ventricles are basically squeezing so fast. It's basically like quivering. And when it's quivering, it's not pumping blood like it should because it's kind of just quivering. It's not doing the actual heartbeat like it should. It's just kind of quivering and shaking, right? It's not actually perfusing the body, right? And these are your dangerous rhythms because if someone is in ventricular tachycardia, they're probably in cardiac arrest. Someone can be in VTAC with the pulse, but it's rare. If someone is in VTAC, they're probably in cardiac arrest. They need CPR. They need defibrillation, right? Torsades de Pointes is a type of polymorphic VTAC, right? And ventricular fibrillation is the heart is extremely irritable. It's the worst rhythm. It's worse than VTAC. This is basically guaranteed that the person is in cardiac arrest. And when this is occurring, the heart is basically unable to contract and it's basically just shaking. There's no P wave, no QRS, completely disorganized, right? So in VTAC, I mentioned the ventricle is kind of just quivering and shaking. VFib, it's kind of the same thing, but it's just shaking. Like it's not perfusing at all. It's not moving any blood. It's just quivering. It's just It's just kind of shaking. So the heart is shaking, but it's not pumping blood. So the person won't have a pulse. And when they don't have a pulse, they're not perfusing their vital organs. So they need CPR, they need defibrillation immediately, right? This is idioventricular rhythm. The ventricles take over pacing at 20 to 40 beats per minute. This is when the SA and the AV node has failed. So, as I mentioned earlier, junctional escape rhythm is kind of like when the AV node takes over as the pacemaker for the sinus rhythm. The idioventricular rhythm is when the ventricle takes over as the pacemaker for the AV node, right? And then accelerated idioventricular rhythm is going to be just that rhythm, but just at 50 to 110 beats per minute, right? Because the ventricles are very slow, remember? So normal would be 20 to 40 beats per minute, and accelerated idioventricular rhythm would be 50 to 110 beats per minute, right? And asystole is basically a rhythm where if there's no electrical activity, the person is basically dead. It's lethal. There's low survival outcome. This is where you see the monitor where it's basically just a straight line on the monitor. So when there's basically just a straight line, that's known as asystole. And that's basically telling you that there is no electrical activity in the heart whatsoever. So 99.9% of the time, the person is dead, right? And CPR is not going to be able to help them, basically. You can't even shock asystole. So VTAC and VFib, you can shock. They're shockable rhythms because there's still electrical activity occurring inside of the heart. And what you're attempting to do with VFib and VTAC is you're attempting to shock that rhythm. So you shock it with a defibrillator, right, at 360 joules. And your goal with that shock is trying to reset the heart back into a normal rhythm. So you're shocking the heart, sending it with a bunch of electricity, getting everything to depolarize at once, and you're hoping that will send it back into a normal rhythm, right? So if someone is in VFib or VTAC, they need immediate defibrillation, right? Because they're in cardiac arrest. They need CPR, they need immediate defibrillation. But with asystole, which is just a straight line, you can't really shock it because there's no electrical activity in the heart. It's not a shockable rhythm, right? So when you have an AED, when you put the AED on someone that's in cardiac arrest, the AED is checking to see if it has a shockable rhythm. It's checking to see if it has VFib or VTAC. If the person is in asystole, it's going to say no shock advised because you can't shock asystole. And I'll show you pictures of these rhythms in a second. So this is VTAC. It kind of just looks like it's just the up down rhythm, right? So VTAC, the ventricle is basically just kind of quivering. It's just literally just kind of like zigzag lines, right? Not good at all, right? That is VTAC, ventricular tachycardia. And VFib, which is the absolute worst rhythm, where the ventricles are basically just kind of quivering really fast, but it's not literally moving any blood whatsoever. It just zigzag lines up and down. And this needs immediate defibrillation immediately, right? Ventricular fibrillation. And this is torsades, which is a type of polymorphic VTAC. And you have like the bow tie here, as my instructor tells me. You kind of have the bow tie. You can kind of draw a bow tie right here. And it's pretty much the same thing as VTAC. Usually, this person will be in cardiac arrest and they will need to be defibrillated, right? It's called torsades de pointes, right? Now getting back to into some rhythms that are not as lethal. This is your idioventricular rhythm. So it's what I mentioned earlier, basically the rhythm of the ventricles when it takes over as the pacemaker. Ventricular escape rhythm, another word to call it. There's no P waves. There's going to be a wide QRS, and there's going to be inverted T waves, and also it's going to be a slow rhythm. So as you can see, this is a slow rhythm because the boxes are far apart. And this is accelerated idioventricular rhythm, right? See that? And this is asystole, kind of a flat line, 99.99% of the time. This person it means they're dead, right? They're not coming back. You can't shock them. CPR is not going to work. It's asystole. It's a flat line. PEA, also known as pulseless electrical activity, is when an EKG says there's electrical activity occurring in the heart, but the person can still be pulseless and not have a blood pressure, right? So as I mentioned earlier, the heart has two different systems, right? It has the mechanical blood flow and it has the electrical system. So as we first talked about, there's blood flow in the heart, but there's also an electrical system as well, right? So someone cannot have a pulse and they cannot have a blood pressure, but they could be in PEA. So let's say someone is on pulse, they're unconscious, they're dead, but you put the EKG on them and it says they have a rhythm, but you feel their pulse and they don't have a pulse. That's known as PEA, right? Pulseless electrical activity. It's when there's still electrical activity occurring in the heart, but the person is still pulseless and they don't have a blood pressure. And you can't shock this rhythm either, right? So as I mentioned earlier, defibrillation. So usually when you're doing CPR and someone doesn't have a pulse, right? You're doing CPR, you're doing chest compressions. The goal of chest compressions is to try to basically perfuse the body for long enough time to basically defibrillate their heart to get them back into a functional rhythm, right? So defibrillation is an unsynchronized shock used for VFib and VTAC. Shock is given immediately. Goals to completely depolarize the heart to allow the SA node to reset. The patient is pulseless. Unsynchronized cardioversion. Patient may still have a pulse. Shocks instantly. Used for VFib, VTAC, and VTAC with pulse. Defibrillation is a form of unsynchronized cardioversion. In synchronized cardioversion, it shocks the R wave specifically. So there might be a scenario where, say, a patient is really unstable and they just have a really, really high heart rate, and you need to slow the heart rate down immediately, right? You could do what's called a synchronized cardioversion, which is where you're shocking someone, but it only shocks the specific wave. Because there's another thing known as the R on T phenomenon, where if you accidentally shock the T wave, you could send a person into cardiac arrest, right? But when someone is in VFib, there's no organized wave, so you don't have to worry about that. But if someone has an organized rhythm and it's really fast and you still need to shock them for whatever reason, you would do a synchronized cardioversion because it syncs to a specific wave and only shocks a specific wave, specifically the R wave. Because we want to avoid shocking the T wave, which could immediately cause VFib or cardiac arrest. So this could be used for the patient is conscious. This should say unstable, but unstable and has a pulse. Used for SVT, the really fast rhythm, we might need to show it down. Or for AFib and AFlutter, if it's really fast and the patient is unstable. Or if someone is in VTAC and they have a pulse and they're conscious, which is rare, right? But this is what a synchronized cardioversion will be used for. It's basically a defibrillation, but just only syncs to a certain thing, to a certain wave. That's why it's called a synchronized cardioversion. So an unsynchronized cardioversion is just what? Defibrillation. right? And this is going back to H's and T's, which are known as basically reversible causes for cardiac arrest, which is not technically important for heart blood flow, but all of these things here can cause cardiac arrest. So just leave it at that. This is what I had to learn from my ACLS, Advanced Cardiac Life Support class, right? And this is going into STEMIs or looking at elevation on the T wave to see if someone is having a heart attack, which I need to do another video on full EKG interpretation, but that will be in a different video. Where I will go over to explain looking at an EKG and telling, is this person having a heart attack, or does this person have high potassium, and is this person having a bundle branch block or a right bundle branch block? But that was my entire PowerPoint going over basic cardiac rhythms and how to read them. So, for example, some of your first questions to ask yourself when you're looking at a rhythm is just looking, okay, just ask yourself, is R to R equal? What's the QRS interval? Is it normal? Are there P waves? Are there T waves? Is it inverted? What's the rate? Right? And just by answering some of those initial questions, and obviously studying your different rhythms, you can get a pretty good idea of what is going on internally with the person's heart. So, yeah. Yeah, I made this entire PowerPoint because I was told that cardiology would be the most difficult part of paramedic class. And this PowerPoint definitely helped me. So I will upload it to YouTube and hopefully it will help someone else because I passed the cardiology exam the first try. So it certainly helped me.